It is a great pleasure to introduce you Dr. Nour Audi. Nour is a New University in Exile Consortium Fellow, which Wesley College is also a founding member. He is now a fellow with the Humanitarian Innovation Initiative at the Boston Institute at Brown University. And he is also a candidate for a master's degree in public health. And Nour actually received his medical degree from Al-Qalamon University in Syria, and then completed his training in internal medicine at Damascus University. And he also has worked in the humanitarian sector in Syria with a focus on primary health care. He will present us his field research in Syria, which is priceless because there is no way to conduct a field research of this scope right now, but we are lucky to have him here because he already conducted the research while he was in Syria. So thank you so much for joining us today, and I'm really looking forward to listening to you.
Thank you. Okay. Thank you, Nazan. I would like to thank the Freedom Project for the opportunity to come here today. Syria, where to start from? So many things, so many angles we could speak about. What today I would like to focus on is the population itself, not trying to kind of take much of the actors or who is killing who, what kind of the situation on the ground in terms of the military operations, just trying to focus on the daily living and the daily struggles of the people, of the population itself. And okay. A 35-year-old woman living in rural Damascus had diabetes since her 20s. She had a stable treatment plan consisted of diet, oral drugs, insulin, and physical activities. In 2016, she started to develop a life-threatening diabetes complication known as diabetic ketoacidosis. And that case necessitated her admission to the emergency department in one of Damascus' public hospitals where I used to work. The treatment was initiated, completed within a few days. The patient got discharged with the prescription of the needed medications. Everything was fine. A few weeks later, she came back again to the hospital with the same life-threatening complication. Treatment administered successfully again, and the patient got discharged again for the second time. The next month, the patient again came back with the same situation. I mean, diabetic ketoacidosis is known that usually don't develop unless there is a clear neglect of treatment. The patient is not following the plan. And something was kind of odd here for a physician to see the same patient come with this life-threatening situation on multiple times in a very short amount of time. Upon questioning, it turned out that the patient had lost her home. She got displaced to a nearby area where she lived with other family members. Also, she lost her main source of income, and she almost ran out of savings during the 5 years and between 2011 and 2016. She was not directly attacked in any way. She didn't have any kind of trauma or injury by the conflict, but she had a concomitant depression that kind of interfered with her ability to adhere to the diabetic treatment. And that was the main reason why she is not able to kind of take the treatment she needed to take. Another younger woman also had the same situation. She had diabetes. She would come to the hospital with diabetic ketoacidosis in a very short amount of time, multiple times per month. And for that girl, she was also displaced along with her family, but in her case, they had to live in unfinished home. So they were not able to find a more of a secure place to live. And for her, she turned out that she neglected her diabetic treatment on purpose to get herself admitted to the emergency ward department, because in the emergency ward department, she will enjoy the luxury of a bed on her own, a warm room, and 3 meals per day. Nothing has dramatic impact on population health like armed conflict. Yet, there is no clear understanding of how conflict really impacts health. The Syrian conflict started as a response to the decade-long of exclusion and political oppression. But the Syrian regime had a strategy of extreme violent repression combined with the involvement of various regional and international state and non-state actors that were driving the main factors behind the current situation in the country now at the moment. In today's presentation, I will try to explain the historical and political context prior to the conflict, focusing on the development of the security apparatus in Syria, or what is called the police state, then attempt to use the framework of health as a social determinant of health to understand how the Syrian population health is being impacted by the ongoing conflict. That is the plan for today's presentation. The political development of the Syrian state. So I would start from the Ottoman time, just to go fast. By the 1990s, Syria was a part of the Ottoman Empire at that time. Then, with the big Arab revolt against the Ottoman with the help of the British, they started what's called the monarch period, which was the only very short amount of period, just for a couple months. But because Sykes-Picot agreement between the British and the French, which was already been in secret 4 years before the end of the Ottoman Empire, the Syrian state, Lebanon, parts of Turkey, part of Iraq, and all of that part got divided between the British and the French. And the French mandate started in Syria and Lebanon between 1923 and 1946. Now, Syria gained its independence in 1945. It was on 17 April 1940, and it was declared as the Syrian Republic in 1946. And that date is still celebrated till today as the National Independence Day in the country. But that stability didn't last long. And the Minister of Defense, his name was Hosni Zaim, did in March 1949, the same year, did the first coup in the whole Middle East, which was in Syria. Then in the same year, another coup happened. Then Adib Shishakli did another coup, and he did two military coups actually. And this political instability continued until Syria joined the United Arab Republic in 1958 and established what is called the United Arab Republic. Under the United Arab Republic, the major person on scene on the political situation his name was Abdel Hamid Sarraj. So he's the person here on the right. And what Abdel Hamid Sarraj did, that before he became kind of a president for the Syrian part of the United Arab Republic, he was a minister of interior, and he had the intelligence apparatus in the country under his control. The intelligence apparatus in the country is based on the French system, which is we have what's called the military intelligence and the exterior intelligence. During the French mandate, all of the foreign intelligence was controlled by the French government in France. And there was just a small office called the Second Office, which was responsible for controlling the borders, making any kind of political dissidents in the country. That was under the control of Abdel Hamid Sarraj by that time. And with the rise of the Arab nationalism, the conflict between the Israelis and the Syrians and the Arab by that time, there was a more of security threats, there was a more of a rule for the intelligence to gain. And that's what Abdel Hamid Sarraj used. And he started to kind of use the intelligence and the security apparatus for the control of the civilian life inside the country. And from there, it's just started to develop over and over again. Then what's called the National Council for the Revolutionary Command was formed, which is mostly by members of the Ba'ath Party, who have been severely present by Abdel Hamid Sarraj. And the three coups that came after the 1968 coup was all inside Al-Ba'ath Party coups. It's just the friends will turning against each other. And by 1970, Hafez AlAsad, he was the Minister of Defense at that time, came to power and established the next period, which is between 1970 until Hafez AlAsad death in 2000. Now, what Hafez AlAsad did, that he developed the security apparatus in the country in a whole total new level. So what was called the second office became, or the military intelligence, became more independent. And before Hafez AlAsad, it was just a small branch inside the Ministry of Defense. But under Hafez AlAsad, they became independent institution. Also, he installed around 15 different intelligence branches. Everyone have its own independence, its own budget, its own organizational structure, and all of them report directly to the president. Even, for example, here, we find, for example, the political security is under what's called the General Intelligence Directorate, which is under the President Security Council. But this organizational structure is not what the situation on the ground. The situation on the ground was more related to legions, how the officer close is to the Assad family, and that legions and that clause would decide how much of institutional and decision power you have on the ground. And Assad make it in a way that every branch have overlap responsibility with other branches in terms of place on the ground or which geography or what kind of issues they deal with. And there was an always fierce competition between them, that sometimes a small armed conflict would happen between those branches. And it was only Assad's hand that he will be able to kind of decide or set the rules around here. And that was the situation even after Hafez AlAsad death. In 1970, when Assad rose to power, it happened what is called the Islamic uprising in part of the country, which was severely. I mean, the whole city, Hamas city the whole city was destructed, just with the involvement of different factions of the intelligence and the army at that time. And it was that event that kind of made the role of the intelligence more crucial in the political life of the Syrians in the country. During Bashar al-Assad era, between 2000 until present, nothing much of the organization structure changed. People would be changed. But at the same time, when the conflict started, we start to see more establishing of pro-regime paramilitary groups. Everyone have with the same issue that every paramilitary group have its own legions, and that legions don't depend on any kind of structure. It depends on family relations and a more of birthplace. If you have a more like high-ranking army officers or high-ranking intelligence officers coming from the same area or the same village the paramilitary groups founded with. And that decided for each paramilitary group where it will be allocated, where it work, how much of a control on the ground have. Some of those militia groups were stronger, have an upper hand even over the army units. So they would target an official army units, although they are just paramilitary groups. All of this depend on how much their leaders have allegiance and have close relationship with the Assad and their family. Now, by 2010, there was a four main branches of intelligence in the country: military intelligence, Air Force intelligence, Political Security Directorate, and the General Intelligence Directorate, with an armed forces of over 100,000 official registered people, registered staff. Those before, during the French mandate, were around less than 2,500. But during this period, we see the enlargement and the involvement in every level of the civilian life. So every intelligence directorate have a branch in the main city. They also have a smaller branch in villages or in small towns, and that's how they operate on a daily basis, on 24 hours, 7 days a week. I mean, we could speak for hours about the root causes of the conflict in Syria. Why did it happen? And actually, do we define 2011 as the start of the conflict? Should we define different time for that conflict? Based on what? I mean, between 2000 and 2011, 7 different small political uprisings happened somewhere in northern part of the country, in Kurdish majority areas, which was also severely oppressed. But in 2011, in March 2011, what was happening that there was the political oppression satisfied the situation on the ground. People were really felt that it's too much. At the same time, there was a rising economic inequalities. So before Bashar al-Assad came to power, the state adopted a socialist economic agenda. But when Bashar al-Assad came to power, he tried to liberalize the economy, but that didn't work well very much. Corruption, mismanagement of public funds and institutions. Also, we could see that the droughts, climate change also played a role. So between 1998 and 2000, a whole river in the northern eastern part of the country dried out, and the whole areas and the whole villages and communities that depended on agriculture in that place had to find a new place and a new kind of way of living, and that was catastrophic. At the same time, people didn't know much about what is happening in those areas. There was rumors about a cholera outbreak in the same areas, but it was just rumors at that time. Also, we see that the Syrian population is young population relatively. Most of the population is between 15 and 30 years old of age, and usually the youngs are the people who revolt. Also, social media played an important role. It played 2 major roles. The first one was people were able to have more of a discussions, more of awareness about their rights. At the same time, they were able to have more of awareness about what is happening in the whole area, what was happening in the Tunis, in Egypt, and they started to think that probably there is some kind of hope to replicate the Tunis model inside the country. Then the conflict broke out, started in the southern part of the country, but spread directly to the other parts of the country. I want to stop the narrative about the political state here and continue what was happening in the country more from the public health point of view. We could speak for hours about the stories of the ground, the people, but there is a lot of resources for that, and I would be happy to refer any person for more resources about what's the beginning of the stories around there. Okay, before we start diving into the public health lens of the conflict, I just want to mention some definitions. So, health for the World Health Organization, it defines health it's just a state of complete physical, mental, and social well-being. It's not just the merely absence of disease and infirmity. So it's not just disease, the absence of disease is health. We are speaking more of a holistic view about well-being of the person. This is what the health is. Also, there is a concept called social determinants of health. So in our attempt to understand how health is being produced and how disease is being produced in a society, looking for the personal behaviors or the kind of a more of a pathologic aspect of the disease is not enough. We need to look for on the conditions in the place where the people live, where they learn, work, and where they play in order to, which affect a range of whole health risk and outcomes. Those conditions known as the social determinants of health. For example, the social environment, which consisted of social structure, political and governance structure, ethnicity, religion, community structure, the family breakup, and all of those kind of impact a lot of intermediate factors such as the economic situation, poverty level, educational level, and health literacy, which is also impact access to health and the brain neuroendocrine functions. All of this will end up as the pathosociological changes that kind of go into organ impairment, and they produce or they impact the well-being, morbidity, and mortality of the population. So in order really to understand how conflict could impact health, we need to have a bigger view of how conflict can impact the whole social aspect of the life, not just directly on the personal life, body. Now, one way of understanding conflict as a social determinant of health, it functions in two main ways. The first one, as a social determinant of health itself, it leads to mainly loss of human rights, breaches to medical neutrality by attack on health and the weaponization of healthcare, exposure to high chronic level of stress, which kind of impact this area here, the brain and the neuroendocrine immune responses, lead to various psychological and direct biological diseases. Also, the other way is by reinforcing existing social determinants of health and health inequalities. For example, income, poverty, access to work, access to health, access to education. Whatever inequalities existent in the society, the conflict will just increase those gaps, will increase those inequalities. And that kind of severe the impact of a conflict on health. The first impact, or the most direct, death. So this is the graph for one of the documentation Syria centers that attempt to document all of the direct death during the conflict, the Violation Documentation Center. And what we see here is the period between March 2011 and around June 2016. Death, this is just direct civilian death. So this don't include state or non-state armed actors. Those don't include non-documented cases. This is just all of the cases that have been documented by name, by location, by date of death, as much accurate as possible. And this is just one source. And what we kind of see that in the beginning, most of the killing was happening by shootings, by small arm or light arms. By the beginning of 2012, we see a more of a heavy weaponry involvement. And around June 2012, we start seeing the involvement of airstrikes. Actually, around June 2012 is also the exact date, the exact month where the International Committee for the Red Cross declared the Syrian situation as an armed conflict. Before that date, there is no such a definition of the situation on the ground as an armed conflict. You could call it whatever you'd like, but it's not an armed conflict. So probably it's more insightful to kind of define the conflict based on the timeline and the development of the way of how people are being killed during this time. I wouldn't call it 2011 armed conflict, I would call it 2012 conflict, but before that it was political uprising or because political chaos, or whatever term you would like to use. Now, counting the direct death. The main sources for the death records inside the country are actually 5 main sources, which is the Violation Documentation Center we mentioned, the Syrian Center for Statistics and Research, Syrian Observatory for Human Rights, the Syrian government, also another website called Syrian Shuhada website. All of them have dedicated staff, people on the ground in different parts of the country that try to document every direct killing happening by either any way of the arms we mentioned before. And so the office of the UN Office for Human Rights try to combine all of the sources in order to understand how much of an accuracy and how much of reporting actually we have on the ground in terms of the direct killing by the conflict. And here what we see is the four main sources, the first 4s, and we see that there is a lot of different in reporting. It's not just the same numbers. And that happened because one of the institutions would be more functional, have reach on ground in a specific place, but another one would have more reach of a ground in another place, depending on whatever faction is controlling the area, and the crossing from one control to the other would be almost impossible. And depending on where is the killing is happening, one documentation center will be able to document those cases in this place more than the other one. And that is one reason why we end up with these fluctuations in numbers. Now, but the change in the documentation of the direct killing, so the conflict, it's not the change in the dynamic of conflict also changed the fluctuation in the documentation. For example, in a specific area where there will be a massacre happen that involved a sporadic 5 or 3 houses, the documentation team will be able to kind of collect the information from their neighbors. But what would be the situation if an attack exposed the whole village? If there was no one left, how would we be able to document those cases? That also could be another reason why the inaccuracies is so high in the attempt to collect the total killing. Here, we see a graph of 4 months, December 2012, January 2013, until March 2013, and the color represent the percentage of the total undocumented killings that was not documented at all in the country. And we see here, for example, in January 2013, Hama Governorate, which is this part of the country, there is more of a 60% of the killing cases in that governorate in that month was not documented at all. The same thing here in Homs during March 2013. And we could try to summarize the challenges facing the killing documentation into duplications, inaccuracies, sometimes a lot of missing data that kind of make it very hard to assert that this person is not the same other person in different database. For example, here we see that, so this is the 4 main data sets. And here, for example, we see that only 4,877 cases were documented by all of the same 4,800 deaths were documented by all of the data sets. But for unique cases, for example, SOHR had 11,877 unique cases that only their database included those killings. And it became really chaotic just to know exactly how much people have directly killed by the conflict. And the process of just try to assimilate all of those databases at the same time, trying to come up with the most accurate number is really mind-blowing. There is a lot of steps that includes data cleaning, data translation into English, which is a step that it involved multiple research at the same time just to make sure that we are using the same letters for the because it's a name, it's a noun, so it's not easy to translate it from one language to the other. If we change different vowels, then are we having now a new person, which is it a duplicate of another person in a different way? So all of those consistencies need to be made sure. Also, data canonicalization. Did I say it right? Okay, which is mean that, for example, in one database, they would document the location, for example, that the location of the death happened on the village level, but the same person in different database, they would design or code the location on the governorate level or on different level. So we need to make sure all of the levels are the same. Also, matching, which include 3 different steps: deduplication, linking record within the single database, its source itself, make sure that there is no duplication within the same data source. Also, what's called record linkage, which is identifying the same death and record found in different sources, different data sets. And the third step would be clustering, which is combining all the matched groups that may have different data into one row. Again, we do a last step, which is re-examination, checking for neighboring time or location. Sometimes a big massacre happened over a multiple of days, but the same person would be registered in the first day and the second day. Or sometimes they decide the documentation date when they reach the location, which is a couple days later. So all of those different way of multiplication kind of impact the accuracy of the data set. Almost all of those processes stopped around late 2015. The UN decided not to do any more documentation of the direct killing. And whenever we try to have an estimation at the moment, the crude estimation is around more than 500,000 direct deaths. This is the crude estimation, but we are no longer able to kind of make sure that how much of the documentation is really accurate at the time, unless we do all of the processes we mentioned before, which is combining the different information sources, making sure that, and this is just the documented direct killing. We did not speak about the undocumented direct killing. So we're just trying to scratch the tip of the iceberg here. Now, we move to the second level, which is indirect death. I mean, there is no indirect death happened for many reasons. Worsening of the social, economic, and health condition in the conflict-affected area. This can result in a variety of different factors that kind of impact health, or in many ways that lead to indirect killing, but also could be considered a conflict indirect death. And for example here, so this is a table from different reports that document the indirect death from different kind of armed groups. We see from Kosovo, for example, here to Iraq war. And for example, we see how much there is variation between the ratio of indirect death. So usually the attempt to document the mortality caused by conflict usually happens post-conflict. The unique about the Syrian situation that this documentation is happening while the conflict is ongoing, which is a bit unique to the Syrian situation. Here we see, for example, Iraq war between 2003 and 2007, the ratio between indirect to direct deaths is 3, which means that for every direct death, there is at least 3 indirect deaths happened in the Iraqi war between 2003 and 2007. And this ratio goes up to 15.7 here in Sierra Leone, and don't go below 3 in any of those studies. And usually there is some kind of consensus that around 4-to-1 is what you would consider a mean ratio of indirect death to direct death. So if we have a direct death of around 100,000, probably the indirect case, it would be safe to say that there's at least around 400,000 indirect deaths caused by the same conflict. And this is actually depend on multiple factors. So for example, the pre-conflict level of the development of the country, the pre-conflict level of the health status of the country, how much fragile it was, how much sick or healthy the population was. Also, the duration of the fighting. A few months is different when it's more than a year. The intensity of the conflict, the access to basic care and services, and the humanitarian relief efforts. And actually, in the Syrian conflict, we have all of those negative factors here. Now, what we're trying to understand at the moment is just this circle here, which is civilian death in armed conflict. So we have also the indirect conflict death, which we were talking about, which is, of course, much bigger. And we have also the non-conflict death, which is not even caused by the conflict. And we're still just speaking about death here. Also, till now, what we're trying to understand here is just how people are being killed by direct or indirect way of killing, but we did not speak about forced disappearance in Syria. Around 2 years ago, Amnesty made a report about most of the notorious prisons in Syria called Sidnaya prison. And what they discovered that at least there is around 75,000 people who have been arrested till that date, till 2015. And between 5,000 to 13,000 people have been executed in that prison between 2011 and 2015. Now we are 4 years later after 2015. So we could speculate safely that the 13,000 is just a baseline here. And all of those deaths have not been documented directly by any of the data sources. This is a different way of death during conflict. It's not a direct trauma related. Now, if you want to step out of the front lines or where the killing is happening, and we try to understand what is the most causes of death in the country. Before the conflict, the main reason of death was ischemic heart diseases. So Syria went through something called epidemiological transition. So for example, if you want to compare Syria with a lot of countries in sub-Saharan Africa. In sub-Saharan Africa, a lot of those countries before the epidemiological transition, which is mean a lot of the death in those countries happening by infectious diseases, happening by lack of treatment and a lot of very fragile state, very limited resource settings that don't enable the basic sanitary situation and the basic situation just to prevent most of the preventable chronic infectious diseases. This was not the situation in Syria. In Syria, have already gone through epidemiological transition, which means most of the deaths in the country was happening due to chronic diseases. So we have ischemic heart disease as first, cerebrovascular diseases, Alzheimer, congenital defects, and we have diabetes here, number 12. And we see that after the conflict, of course, the conflict became one with an infinite change, increase. Ischemic heart disease became two, but not because the rate of the death by ischemic heart disease decreased. No, just it's a more relative. So actually there is, according to this study, it's a more 14.6% an increase in the rate of ischemic heart disease during the conflict. And this is aside from the front line. So we are speaking about people still feeling safe or people who have been displaced but without direct interaction with the armed factions on the ground. The same thing for other diseases, and we found the diabetes, like the patient we spoke about in the beginning, that it rose from number 12 to number 10 with an increase of around 38%, which is too much. Now, why those kind of death happening? What would be the reasons behind that? Actually the erosion of the basic life necessities in the communities is basically the main reason behind that. So food security, for example, was a main reason. We have also access to water, access to clean water. Environmental pollutants. So specifically in some of the besieged communities that were cut from the outside world, the need. So here, for example, we see what's called a plastic refinery factory, which is basically they burn plastics in order to get fuel out of that plastic. And this fuel would be used to run electric generators for the underground hospitals or for the school, for every kind of very important life necessities. And in most of those factories, actually there was a lot of children working in those factories. And it's known that the fumes coming out of those refineries are carcinogenic, and there is a lot of carcinogenic elements and compounds in those refineries. This is photo from Deir ez-Zor, northeastern part of the country. So every black dot here is a man-made oil refinery. So what they will be doing, that they will be trying to extract the oil directly from the ground, burning the oil in order to separate it into different compounds, and then try to sell it directly in the market. And this is really carcinogen. And there's a lot of carcinogens coming out of those refineries also. So we see that the loss of the basic rights, of the basic human right to safe environment, to access to water, and food security how could impact health. But if you want to move to the next axis in the conflict as a social determinants of health, which is access to health or the loss of neutrality of health. Another aspect very unique to the Syrian situation is how much strategy was there in terms of the attacks on healthcare. And a whole term which is called the weaponization of healthcare came out of the Syrian conflict, which is defined as a strategy of using people needs for healthcare as a weapon against them by violently depriving them of it. So for example, in Syria, there was at least, until 2017 here, there was at least 814 medical personnel have been targeted and killed by the conflict. At least by 2016, almost 200 different medical facilities have been directly targeted whether by airstrike or by heavy weaponry. Some of those facilities were targeted multiple times. There was a very famous hospitals in the central part of the country around Hama, which was inside, so they built it inside the cave just to make it as more secure as possible, and it was targeted more than 5 times. And it was destroyed at the end. So it's not just by accident, it's a deliberate strategy run by this in order to win the war. So this is a photo for Dr. Ali. Dr. Ali was the first doctor who was killed during the Syrian conflict, and he was killed actually on the 23rd of March in 2011. And this is just like 2 weeks since the break of the whole political uprising at that time, before the development of the armed conflict or the development of any different non-state armed groups in the country. And we see the increase. So here is the categorization of the medical personnel death by different specialty. We have doctors, nurses, medics, pharmacists, even medical students. Now, if you understand, it's not just about, if you want to measure disease, how we would measure disease. I mean, death, it's kind of direct. The person is either dead, died, or alive. But for disease, it's kind of more complicated. So there is this measure, which is called years lived with disability, or years lost due disability. This measure tried to kind of estimate how much people lost by different diseases and how much disability caused by those different diseases and how much that impacted their life in terms of how many years they would have lived in health without this disability. And we see that the main reason for disability in the country before the conflict was headache disorders, low back pain, depressive disorders, drug use disorders, and we here see the emergence of the non-life-threatening diseases. So we don't find here any more cardiovascular disease because it cause death more than it would cause disability directly. We see more of the diseases that don't impact the life directly. And even after the conflict, we don't see much of a change in those situations. We still see low back pain among the first, in the beginning, conflict and terror also, headache disorders and depressive disorders. An estimation by the UN that now around 1 person every 5 people have some kind of psychological complaint this is just among people still inside the country at the moment. Now, if you want to take it even a step further, which is then now what we're trying to establish is we are measuring health by some kind of a health personnel. So the health personnel would decide how much, if you have a low back pain or not, would decide you have diabetes or not. But there is a model called Health-Related Quality of Life, which says that it's a social science program, which says that we could measure health directly from the perspective of the patient themselves. This is really important for example, for cases when there is no cure, cancer, or any cases that there is no cure. So the decision for the treatment would not depend or should not be dependent on the physician decision making, on the physical situation of the body. It would depend how much the patient will feel kind of more functioning or what kind of aspect of his life he would like to kind of move or try to kind of fix. And if we try to use that model to kind of see how much the whole population, even those who don't have disease, could be impacted by health, what kind of data we could get out of this. So this is the study that I did in the country before coming to Brown. Between 2015 and 2017, I was working in the two main public hospitals in Damascus, Al-Muwassa and Al-Asad hospitals. And what I tried to do is kind of measuring the impact of the conflict through a scale called the multidimensional loss scale. What the multidimensional loss scale is, it measures loss across 5 domains: personal, social, material, intrapersonal, and culture. So for example, it would ask the person, have you experienced leaving your home? Have you experienced leaving your village? Have you experienced leaving your town? Have you experienced losing a family member? Have you experienced the death of a family member? And so on. Have you experienced the loss of your work, for example, or the loss of your music or food, for example, in terms of the cultural domain? And the question would be yes, no questions. And I used a different measure in order to measure the quality of life for those patients, which is assess the quality of life in the 30 days preceding the assessment. And so I will be asking the question of the patient, are you able to do the following? How much do you feel you could achieve the following? Which is basically say you rank it between 1 and 5 from no difficulties at all. For example, I could walk 100 meters without difficulty. I could go visit a friend without any difficulties. Or they would be saying, no, it's extreme difficulties between 1 and 5 levels. And so there was a total of 79 patients coming from different parts of the country in order to receive treatment in those hospitals. This is not just because if they were trying to get a better or higher quality of services, but because probably in most of those areas there was no any kind of health services, so they needed to come to Damascus just for the sake of getting a health care. And we see that the majority of the patients were from rural Damascus, which is around this red area here. Also from Damascus, which is also makes sense. I mean, the nearest patient would be able to come or cross easier to the place. But even people coming from Al-Hasaka, for example, which is in the most far northeast part of the country, 2 patients, actually 1 patient came from that most far away place here. So there was a total of 79 patients, at least 73% were women. And the diseases that were kind of under study are called rheumatologic diseases. So this is something called like rheumatoid arthritis, systemic lupus erythematosus, and other kind of rheumatologic diseases. And those diseases are very sensitive in terms you need a specialized rheumatologist in order to get the treatment right. If you don't get the treatment right, or you get different kind of drugs, you end up having a high disability in a very shorter amount of life, because it affects joints, affects musculoskeletal systems, so it's very apparent on the functioning and the disability of the patient. And we see here that, for example, so what is between the barracks is the number of the patient, what is outside the barracks is the total percentages. So for example, 67% of the patients were internally displaced, which is mean they have lost their home, they were forced outside of their home, but they did not leave the boundaries of the national state of Syria. So they are not refugees yet. They are just internally displaced. And 57% also had to leave their village. We see also, for example, 50% experienced at least death of one family member. Now, the exclusion criteria here was trying that none of those patients have any direct impact by the conflict. So none of them have been shot, none of them have went through torture or arrest or any kind of loss of the human rights. They were just living beside or neighboring the conflict, but not inside it directly. And it turned out that among those arthritis patients who had the luxury of accessing Damascus health services, which considered the best available in the country, between 2015 and 2017, for every additional loss caused by the conflict, the health-related quality of life deteriorated by 1%. So the questionnaire would assess losses, a maximum of 24 loss. So if you have a 24 loss, if you have all of those different losses, you at least have a 24% deterioration in your quality of life and functioning by just having those losses. And this was kind of the research that I did. Of course, we didn't go through everything. We didn't speak about the refugees yet. We didn't speak about maternal health and pregnancy outcomes. What happened to children in their mother wombs when the mother is not able to access enough nutrition, or when she's living under constant stress for the whole time, or she's living in a very contested place where there is no good quality of air, or no good quality of water, or no good quality of anything else. What is happening to the children's development, aside from traumatic disorders or experiencing traumatic experiences? How is living in a conflict situation impact your development from the early days of your life? What else could we try to mention here? So this is just I didn't try to come with an answers. I was just trying to kind of drive questioning and just to see the situation from the different lens than whatever the media currently try to engage with. It's a more dramatic to kind of see who is fighting with, what kind of weapons they are using, but the situation, but the people on the ground is living in total different reality. In many cases, and most of the time, they don't even have the luxury to know about those kind of interests. And thank you very much. Questions?
So it looked like if I read the chart right,
Yes.
well, one of the many charts, it looked like mental health outcomes during the conflict period improved.
Well, this one?
Yeah, so it looks like all of those change numbers are negative for depression, drug addiction, and anxiety disorders. And so I was wondering if you thought, I can think of a couple of reasons. One is that accounting for those kinds of things becomes harder in conflict periods, or just...
So this is basically not based, this is an estimation of an estimation. It's called the Global Burden of Disease Study. So it's not directly being built on an actual data at that moment. But at the same time, you see there is kind of decrease. Okay, but I wouldn't speculate that easily. I would be cared more about their relationship in terms which is the top 10, which is the first, I would be care more about the order more than the equal quantification of the burden itself. So we were not able. I just tried to explain the challenges faced just measuring the direct death, which should be the most obvious and the most simple one. But even that one is really challenging. And if we try to move any further, try to understand any more kind of impact, it became more complex, and it's hard to be assertive of the information, yes.
Thank you very much for your presentation. You've done really good work, and I know like there's so much data missing, but this is still very excellent and something to go off of. I'm from Kashmir, which is also a conflict zone, and of course the magnitude of the severity of the conflict is nothing compared to Syria. Doctors Without Borders did a study there a few years ago, and they had about 45,000 people in their sample, so it was a pretty robust study that they did. And what they found was half of the population had PTSD. So people in Syria having gone under such a severe conflict and still living there, I think this is like such an understatement. And of course these numbers, I think we should just look at how they're ranked and not the magnitude actually. And I think you mentioned that 1 out of 5 people has some sort of like mental health issue, but I think that's a huge understatement, first of all.
But again, I mean, thank you for your notion, but I mean, what the case I try to make here, that there is a high rate of undocumented killing. How much rate there is of undocumented disease there is. So that's why I don't try to mention a lot of the numbers being used at the moment, because it's just an estimations, and I wouldn't be kind of grip on them very hard.
A question that I had was, so a lot of the health facilities got destroyed by Assad regime. So which hospitals are functional, and how is the demand for health facilities being met at the moment?
I mean, there is documentations of the health resources in the country just from the public health resources. Before the conflict, the health system is a multiple of a lot of private and public hospitals. We don't know much about the private sector, although it was contributing a very significant amount of health services to the population. What we know is just about the public sector. And what we know about the public sector, that is at least 50% of the hospitals are not functioning. And I'm just speaking about hospitals. But in Syria, it's different from here. I mean, the main service providers are clinics on the ground. I mean, just people, physicians would get their training done, then try to open their own business in their area or in different place. And if you see the number here, actually 15,000, which is 50% of the total doctors in the country, of the total healthcare workers in the country, have left the country already, are outside the country. Between 2015 and 2016, for example, there's the city of Aleppo that was under heavy besiegement and heavy bombardment. The eastern part of the city, which was under besiegement, it was functioning on just 35 doctors at that time, for a population of, I'm not sure of the number, but I think it was over 1 million people living at that, so what we see here is not just an increase of demand, an increase of we see a decrease of supply at the same time. So we see, I mean, the population just get tiered in every possible way. Yes.
First of all, thank you very much for this presentation. I believe only those who just have a real field research experience could really appreciate the value of this research, given the circumstances under which you collected all of this data and process everything. I have multiple questions, because I mean, this just presentation arising multiple issues, in one single presentation. First of all, I wonder what you think about the impact of the military operations of the Turkish government in Syria on public health in the northern part of the Syria, for the last 2-3 years. The second question, as far as I understand right now, there are lots of different military groups in Idlib, in a sense constrained by the regime, and other forces as well. So the conflict right now seems to be much more concentrated, geographically concentrated in that area. So do you have like any reading of this in terms of again public health dynamics with regard to the same, let's say, region? So like there has been so much debate about this group called white helmets. So I kind of wonder what to think of this particular group, because so much speculation of what they were doing, like in terms of let's say their activities. I'm curious about your this insight about that. Last but not least, so I just had this opportunity to conduct some research in Gaziantep in Turkey. So like by the border of Syria again. My research was not about Syrian refugees as such, but about industrial production in that city. So Gaziantep, right? So my observations were much more about the Syrian workers from Syria, and there were again lots of let's say public health issues, because they were forced to work in the most, let's say, dangerous areas and sectors, such as in the shoe sector, for instance. They just were exposed to much fume and also some chemicals. Have you ever encountered to any kind of research that in a sense compare between the situation of the refugees and let's say people in Syria exposed to different sources? You already said that this is beyond your scope of your presentation, but I just would like you to speak a little bit about that. Thank you.
Well, thanks you for questions. First, the way, for example, I look for different factions' impact on the different population on the ground isn't just in terms what kind of tactics is being used, or what kind of heavy is there heavy bombardment, is there a strategic attacks on the healthcare in that place or not, what is kind of things. And I don't have a direct information about what is happening in the north, on the northeastern part of in the country at the moment, but I think it's bad, but I don't think it's as bad as it was the situation, for example, in the besieged areas. Just relatively speaking. Unfortunately, the refugees health, it's beyond the scope of today presentation. What I was trying to focus on is the people inside the country, which is, I think, they have less attention at the moment. There is more resources, there is more studies about refugees' health in different European countries, Jordan and Lebanon and Turkey, compared to how much data we have about people still living inside the country. What we know that the estimation of UNHCR that is around 6 million or 5.9 million Syrian refugees, which is basically around 33% of the whole total population that live the country. So I don't know much about the health situation of the Syrian workers in Turkey, for example, at the moment. What was the last question?
Idlib, and I'm curious about what you think about white helmets. As a group, who just made a lot of appearance in social media. Did they really contribute, possibly to the public health in Syria during the conflict or not?
We need to try to understand the perspective outside of the politicization that is happening. And there is a lot of international organizations working in the country, whether international or whether local, that have been formed or organized during the current conflict. And many of the key players, we don't know much about them because the media campaigning or the political aspect of their activity is just not important for them. That's what I could say at the moment. Thank you. Questions? Yes.
I was really impressed with the number of different organizations that were estimating the deaths up to that moment in time when it just stopped.
Well,
And
yeah.
I'm wondering, will there come a time, is it foreseeable that organizations will begin again to try to estimate?
So they did not stop estimating. What was stopped is the collective effort of building the whole different sets into one and try to have a systematic analysis that is based on an epidemiological science in order to make sure that we have like an accurate result. This is what was stopped, but the documentation was already happening. And what was stopped also is the official UN adaptation of the counting of the killings. That's what did stop. It's not the documentation did not stop at all, as far as I know, as far as my information is. I mean, I'm not involved in that aspect of work, but this is my information. Yes.
Who else is providing healthcare other than medical personnel who were in Syria already? Like, which international organizations are like trying to provide healthcare in Syria, or are they even intervening in the situation?
So, I mean, in Syria, who is directly providing healthcare on the ground are just local national healthcare personnel. There is no international healthcare personnel directly on the Syrian ground because of the security situation, because of how dangerous that is. I mean, that happened for in like an individual attempts, but it was not a whole collective organization trying. It's different from Afghanistan, for example, different from Haiti, different because of how systematically attacks on healthcare. So, but I mean, organizations are different based on who have the control on the ground, and usually humanitarian organizations working from Damascus don't work in areas that is not controlled by the state. They will lose their license, they will be evicted the next day directly. If there is any kind of evidence that there is any kind of financial relationship with any local organizations working in non-state controlled area, and that happened. The same thing in the opposite direction. What I know that MSF attempted to work in Damascus, but they did not get the license because they already have been working in different areas of the state. So there is also this kind of politicization. So it's not just weaponization of health. There is the politicization of the whole humanitarian intervention. And this is not just unique to Syria. I mean, it's the situation in every humanitarian catastrophe. But once one need to kind of read beyond what is being directly reported. Thank you. Okay, thank you very much.